Our next presenter, Dr. Lauren Krueger. She is an assistant professor in the Department of Dermatology at Emory University School of Medicine in Atlanta, Georgia. She is a medical and procedural dermatologist and serves as associate program director for the dermatology residency. Dr. Krueger received her medical degree from University of Wisconsin, Madison School of Medicine and Public Health. She completed her dermatology residency at New York University, and her areas of expertise include pigmentary disorders, hair loss disorders, and skin of color dermatology. She also serves as the vice chair of diversity, equity, inclusion for the Department of Dermatology there at Emory. And she's published numerous journal articles ranging in topics from bias in dermatology to the history of hair care practices in the US. And so I'm just so happy to have her join us today as she will be discussing recognizing and managing disorders in curly hair. Welcome, Dr. Krueger.
Thank you so much. Thank you for having me. I was surprised to see the change in order. I was like, that is going to be a tough act to follow with that first speaker. Oh my goodness, what a tremendous honor, though. The list of speakers on today's agenda are just amazing. So thank you for including me. I want to just confirm that you guys can hear me and see the slides fully.
Looks great.
Okay, awesome. Again, thank you. So I'm going to be talking about something that truly excites me, recognizing and managing disorders in curly hair. This is such a broad topic, but it is a beautiful intersection of science, disease, and culture. And I think that's what makes it so interesting. Again, I'm Lauren Krueger. I'm an assistant professor at Emory in Atlanta, Georgia, and I'm the vice chair for diversity, equity, inclusion. I have no financial disclosures. I do have to thank my gracious patients. I'm so appreciative of them letting me care for them, but also for allowing me to show photographs. Some things we'll be talking about today. So I'm going to review scalp and hair disorders that occur in curly hair. Many overlap with straight hair, including those, however, that have increased prevalence in curly hair. We'll talk about differences in hair across racial groups, the tools we have to classify hair texture and curl pattern. We'll cover principles in developing a hair care routine, which is something that we get asked about so often, but it's hard to answer these questions. And then we'll examine the new literature on cancer risk in regards to hairstyling practices. My guess is you have seen or heard some questions regarding that topic. So let's get started with kind of our quintessential hair loss disorder, subtypes of alopecia. You may not necessarily think about this in combination with different, racial predilections. However, this is alopecia areata, right? A subtype of alopecia that we think is autoimmune in nature, commonly presents with circular patches of complete hair loss, non-scarring. More severe forms are ophiasis pattern, which occurs in a band-like pattern across the frontal scalp, alopecia totalis, and universalis. There are new studies actually to suggest that there are racial differences in the prevalence of alopecia areata. So a recent study from the JAD in 2019 identified that there's an increased likelihood of alopecia areata in Black patients relative to white patients with an odds ratio of 1.92. There's also a greater risk of persistent alopecia areata, as well as more severe forms, so totalis and universalis, and that odds ratio is 1.57. So early identification is key, especially in that ophiasis pattern where we also have FFA and traction. We know that the longer you go on without treating alopecia areata, the more difficult it can become to get response. It can become to get a response in terms of hair regrowth. Also, another study in the JAD from 2022 found that in Black patients, alopecia areata occurs in younger patients, so a younger age of onset, with an increased prevalence of atopic conditions such as allergies, eczema, etc. So Even with alopecia areata, which we view as kind of one of our quintessential subtypes of alopecia, there may be some racial differences here. And then, all of us have seen androgenetic alopecia, male pattern hair loss. This occurs for sure across all ethnicities, racial groups. We do see it in Black patients as well. So this is a photo of a patient I have with androgenetic alopecia. You can see that there's decreased density kind of uniformly at the crown of the scalp, which is going to be different than CCCA, which may have actually patchy loss. It's not quite so uniform. Unfortunately, there aren't good studies that really characterize differences across race and androgenetic alopecia. One thing I will tell you anecdotally is that there's still going to be your variation in hair shaft diameter noted on trichoscopy. Also look for your vellus hairs. But more globally, what you may notice is that there tends to be a transition to less curly or straighter hair and finer hair. So that miniaturization of the hair follicle that's happening, and curly hair types may present with a different texture of hair at the crown of the scalp. So that's something you can use. Many hair loss disorders occur at the crown of the scalp. I think it's important to have a good differential here. So this you may see, and this may look exactly like androgenetic alopecia, right? There was a recent case series, however. When you go in with trichoscopy here, what you see is significant perifollicular scaling. So if you're seeing clinically someone that looks like androgenetic alopecia, make sure you are always taking out your dermatoscope. You're going to look for that variation in hair shaft diameter, which I'm hoping you're seeing my mouse here. Variation in hair shaft diameter, right? Some that are much thicker, much thinner. But you also get perifollicular scaling in this view. And it's not patchy, it's kind of uniformly in this area. This is a new entity that has been described in a case series of skin of color patients called fibrosing alopecia and a pattern distribution. So you'll get overlapping features of androgenetic alopecia and lichen planopilaris. It does not expand centrifugally. It kind of usually starts as that kind of diffuse vertex involvement, but there's significant perifollicular erythema and scaling in up to 87%. So something else to keep in the differential for central scalp hair loss. And then of course we have frontal fibrosing alopecia, which is often confused for traction alopecia. So very important to be able to make the distinction here. These are a few of my patients. Some clues in distinguishing traction from frontal fibrosing is to look around in other areas. So here you see facial papules, kind of at the temple. You'll often see a pseudo fringe sign. So frontal fibrosing alopecia will typically have complete loss with lonely hairs that are kind of studded throughout. So terminal hairs that seem out of place because they're studded throughout. But a pseudo fringe sign, contrasting to a fringe sign in traction alopecia, can also be seen. Here she has glabellar redness. Glabellar red dots have been described, as well as facial papules. And then something you have to keep an eye out for is pigmentation. So in my skin of color patients, usually you can find some pigmentary disorder, likely lichen planus pigmentosus, that is traveling with frontal fibrosing alopecia. So many cutaneous associations. There's the facial papules we've spoken on, eyebrow loss, body hair loss, depressed frontal veins, glabellar red dots, rosacea, and of course, lichen planus pigmentosus. And we do know there are some differences from this study that were highlighted between white patients that develop FFA and Black patients that develop FFA. So in Black patients, there's often a younger age at presentation, so age 53 versus 63 at presentation. Remarkably increased rates of pruritus. So the odds ratio here was 18. So listen to that sign of itch as a sign of disease activity. Increased rates of facial hyperpigmentation. Thank you. And less likely to have follicular hyperkeratosis and scale, and that's going to be key. So this is actually a patient of mine. She's partially treated now, but even on initial evaluation, mainly what you're seeing is significant recession of the frontal hairline. There are kind of these studded terminal hairs that seem out of place for a normal frontal hairline where you'd have more vellus hairs. There's some follicular prominence, which is hard to pick up in a photo, but if you've ever seen in scarring alopecia, there's just a more visible follicular prominence. That's here. But when I go in with dermoscopy, I'm not seeing much perifollicular erythema or scale. And that's something you have to keep in mind with your skin of color patients with FFA. You may not capture that perifollicular erythema and scale to the same degree. So all those diseases I mentioned are definitely, well-defined subtypes of alopecia. They happen across all races. But then we get to those disorders where science, disease, and culture truly overlap, and that is so interesting. So let's talk about, for example, central centrifugal cicatricial alopecia, or CCCA. This is a type of scarring hair loss that occurs in approximately 5 to 6% of Black women. We know it starts at the crown of the scalp and very slowly centrifugally expands, right? So here's an earlier phase of that. You'll notice breakage. So breakage at the crown is one of your first signs of that. So her locks were actually falling off. It goes on to progress. It has that shiny appearance. You actually can see some follicular prominence here in that shine, and can progress and significantly impact quality of life, right? So this is a more severe case of CCCA. And our understanding of CCCA has truly just exploded, especially in the past 10 years, I would say. So this was initially described and coined hot comb alopecia. It was thought that the heat from the hot comb would travel down the hair shaft, make it to below the skin surface, and cause some low-level inflammation happening around the follicle, which caused scarring. This began to come into question because the use of hot combs actually decreased with the advent of chemical relaxers. And also because we're realizing that CCCA happens in very young patients. So how much styling really could have occurred before the CCCA developed in a very young teenager patient, for example, that we're seeing present with CCCA. It was recoined follicular degeneration syndrome. On PATH, you see that premature desquamation of the inner root sheath. And then it was named CCCA in 2003. In 2018, we kind of had an explosion of studies. So looking at fibroproliferative genes, wondering if there's more of a hereditary component to this. There's an association with uterine fibroids. So maybe fibrous tissue is a bit different here. Also an association with diabetes. Gene PADI3 was proposed. So the way we've begun to understand CCCA is less of a full reliance on a styling practice and more of a role for fibroproliferation based on your genetic predisposition. So this is a patient of mine. She was first seen at age 13 and really hadn't used any heat styling practices such as a hot comb or a chemical relaxer. She came in with decreased density at the crown of her scalp here. She's had a very difficult course. She's been on Plaquenil. We've done intralesional triamcinolone, topical clobetasol, tacrolimus, and minoxidil. And she is stabilized now, but still has some scarring that you can see in the central scalp. But the fact that we're developing features of CCCA at such a young age and in families, that has raised questions. So this was first investigated in 2014. This was a study published in JAD coming from South Africa. And what they did is they looked at a role for genetics. So this is a pedigree analysis that looked at 14 index African families, and 31 immediate family members were screened. And what they found was CCCA does happen in men, but much higher ratio happening in women, with an average age of onset of 41 years old. 48% with those with more severe CCCA had a history of braiding or weaving, but they actually favored an autosomal dominant inheritance to CCCA. Then, of course, there's this game changer article on PADI3 that occurred in the New England Journal of Medicine in 2019. They did exome sequencing of a discovery set of patients with alopecia. They found a mutation in PADI3. The mutation is likely responsible for protein misfolding of peptidyl arginine deaminase type 3. It's expressed in the epidermis and in hair follicles. And what they found subsequently is that 24% of women with CCCA were found to have this PADI3 mutation. So this is really a game changer, being able to name a gene that has identified a variant in CCCA. Subsequently, additional studies were done. This is a study where 2 scalp biopsies were performed of 5 CCCA patients. And what they did is they looked at normal and affected scalp, and they compared the upregulation of genes in these areas. And what they found was there significantly increased rates of upregulation for those genes or those proteins commonly associated with fibrosis. So matrix metalloproteinases, collagens, platelet-derived growth factor, etc. So there are differences in fibrosis that are happening here versus unaffected areas of scalp. And they went on to look at severity, and they found that clinically severe CCCA had increased levels of MMP9, SFRP4, and MSR1 relative to focal limited disease. So there's differences in gene expression happening here. So based on this and these studies, our understanding has shifted. So instead of thinking that this is a reaction pattern from hairstyling practices, we now know that there is a genetic predisposition to fibrosis. The fibrosis primes scalp follicles, and when whatever environmental trigger occurs, which we haven't been able to really give that a name yet, a lymphocytic autoimmune response is triggered, and that increased TGF-beta cascade subsequently leads to fibroproliferation and fibrosis. And then a question you'll get often is, well, I've heard it's related to relaxers, or I heard it's related to hairstyling. So what's your understanding of that? How should I be styling my hair? Well, I like to approach that with, what does the evidence say? Because if I'm going to ask someone to change their hairstyle, that has tremendous implications in their life, right? That affects them financially, in their workplace. All of these aspects that really go into how you wear your hair. It's easy for me to casually say, I want you to switch your style, but that has huge implications for an individual. So what do we know that should really drive that conversation? So there are 3 main studies that really looked at hairstyling and CCCA. It's actually the smallest that suggests there is a relation. So that came out of Nigeria in 2005, 39 subjects, and they found that prolonged and frequent use of chemical relaxers were associated with CCCA. However, subsequent studies, and larger studies in fact, have found no evidence for that. So a study of 101 subjects from 2009 found no correlation between CCCA and the use of hot combs and relaxers. However, there was a strong correlation between pulling or weaves, extensions, tight braids, etc. Probably our largest study to date of 529 subjects that was published in JAD in 2011. That's actually the study that defined that prevalence is around 5 to 6%. They found no association with extensive central hair loss with hot comb or relaxer use, but they did find an association with bacterial scalp infections. So this is important to keep in mind when counseling patients. So right now, we do not have clear evidence that chemical relaxers or heat are necessarily tied to CCCA. Now, I'll talk about this shortly. They are, of course, tied to other forms of hair loss, such as traction, acquired trichorexis nodosa. But if you see someone with healthy appearing hair and hair shaft, and what they're really coming in for is CCCA, be mindful of what we're asking them to do in terms of changing their styling. So these are 2 photos, dermoscopic photos of traction alopecia. You can see very clearly hair casts here. There's even almost a flambeau sign, that white color that's coming from the base of the follicles. So hair cast, flambeau sign is definitely features of traction alopecia, as well as here's probably a pustule, some inflammation. This These styles are too tight. You can see these are likely braids here as well. So identifying that is going to be crucial. We see this all the time, and this is a hair loss disorder where styling directly impacts and worsens the hair loss. And so how should we counsel on healthy hairstyling to avoid the development of traction alopecia? A really great resource for this is actually a publication from the JAD in 2016, All Hairstyles Are Not Created Equal. This has beautiful tables on high risk, low risk, strategies for mitigation, etc. But just to summarize for you. So high risk styles for traction alopecia. So combining tight styles with chemically relaxed hair is your biggest no-no. So if you are going to wear things like braiding, weaving, try to do that in non-relaxed hair. So you may have to suggest to your patients, well, are you going to continue the relaxers? Because then we should avoid high tension. Or if you're going to use the braids and the plaits and the weave more commonly, we should switch over and consider stopping the chemical relaxers. Of course, any hairstyle that causes pain, redness, pus bumps, it should be taken out. This is really hard, and I'm happy we have some hairstylists on the line. But if someone's suggesting to you that the style is painful or if it's too tight, it would be best to prevent traction alopecia to just redo that area in not so tight of a form. And also, clients and patients should feel empowered to say, oh, this hurts, I think it's too much. Of course, tight braids and locks are also high risk. And then frequent use of the same style, tight buns, etc., those put you at higher risk. Lower risk, so natural styles with minimum tension, loose plaits or braids, and then a glue-free wig worn with a satin cap underneath are lower risk. Not always feasible for everyone, but important to know. And then what strategies can we use to mitigate risk? So we've already talked about it. If a style causes pain, redness, pus bumps, let's ask for it to be removed. And alternating styles will remove extensions every 3 to 4 weeks and remove braids after 2 months. Alternate styles frequently, so don't consistently have the same part lines for the same braided style, braiding the hair in different patterns if you're going to do a sew-in weave, etc. So alternating that style frequently allows for tension to be kind of distributed in different areas of the scalp at different times. Avoiding chemical relaxers in combination with high tension styles, larger braid diameter helps. Avoiding glue, sewn in tends to be better. And then after taking down a style, allowing the hair cuticle time to repair and allowing time with less tension before you apply heat, chemicals, or another high tension style. Now, we all know that especially end-stage traction, end-stage CCCA, end-stage FFA, these things are hard to treat. So patient comes in, sometimes you may feel hopeless, and they certainly may feel hopeless. This is where I would encourage you to always be on the lookout for concomitant hair disorders. So even though some of our scarring forms of hair loss are difficult to treat, we can treat the other things that are occurring with it. What do I mean with that? So oftentimes we see itch in CCCA. Well, does your patient also have seborrheic dermatitis? Is there interfollicular scale, redness, growth scaling? Because we can improve itch with using cyclopyrox shampoo, over-the-counter Neutrogena T-gel, perhaps suggesting we wash and shampoo with braids in, or increased frequency of washing and shampooing to at least every week to 10 days. Do they have androgenetic alopecia? So in addition to seeing areas with loss of follicular ostia, are you also seeing significant vellus hairs and variation in hair shaft diameter or pigtail hairs? Let's beef up our treatment for androgenetic alopecia and see how much we can get in terms of that. So adding on minoxidil 10% solution or ointment, adding on an oral minoxidil, considering finasteride or dutasteride, which also have some benefit in scarring alopecias, that helps to treat the component of androgenetic alopecia, if we can thicken up some of those hairs to become terminal hairs, that's still, an important step for improvement. Of course, traction alopecia, counseling on hairstyling practices. But then there's one we commonly forget, and it's a little bit more subtle and difficult to recognize sometimes, and I think it's important for us to give it a name. And that's acquired trichorexis nodosa. So this is hair breakage. So not necessarily hair loss at the level of the scalp, but hair breakage. So what you see is variable lengths of hair, split ends. The hair may lack luster, appear dry and brittle. This is where we can also emphasize our counseling on hairstyle practices to improve the length and strength of the hair and overall give an appearance of more density. And this is also where I'm ordering lab work. So do we have everything we need to regrow healthy hair? Thinking vitamin D, zinc, ferritin is a marker for iron stores. You like that one greater than 50 or 60, as well as checking for TSH, which can cause dry, brittle hair. And I will just give you the hint. These are some of my happiest patients where I'm doing very little for them aside from giving them strategies and tools to improve their care for their hair. And that ultimately results in a wonderful outcome. So this patient came in, I diagnosed her primarily with acquired trichorexis nodosa, secondarily, maybe very early CCCA based on dermoscopic findings. I think I started topical tacrolimus as well as topical clobetasol. She's used that maybe for 6 months max. Most of what I spoke to her about was using leave-in moisturizers, changing her product use, decreasing heat. And here she is, post having dyed her hair. Okay, so she implemented everything I suggested, but then it felt so good about her hair that she was able to style it and dye it here. So this was just about how you take care of your hair. So what is acquired trichorexis nodosa? So trichorexis nodosa is essentially hair breakage or changes to the hair shaft that result from extrinsic insult. So it's going to present to us as lack of growth or breakage. And it's occurring especially in curly textured hair because there's decreased sebum transfer and protection. So this is an important point that I'll talk on a little bit later, but I think it's also important to mention here. So curly textured hair is more susceptible to acquired trichorexis nodosa for many reasons, but one of which is there's a lack of sebum that makes it down the hair shaft to coat the hair and protect the hair. There are many evolutionary advantages to having curly hair. It provides a dense coverage of the scalp. So in areas, we think about ancestors being in the sun, having that dense coverage protects against skin cancer. Also, it moves the hair off of your shoulders. So think about thermoregulation. So having dense curly hair is a benefit. But what it means is that sebum, which is produced the glands of the scalp, because curly hair is not straight, the sebum is not as easily able to make it down the hair shaft and coat the entire hair. And instead, it gets kind of trapped just at the level of the scalp, which is why we see seborrheic dermatitis more commonly and why we see dry, brittle hair and breakage more commonly. Also, because of the curvature of curly hair, there are many inflection points and areas that are finer, which result in breakage. So on physical exam, you'll see hair of various lengths, you'll see frayed blunt ends, and then a hair pull test may actually result in truthfully broken hair. So if you take hair, you notice, wow, this is a hair pull test. Several of these hairs seem to be broken. I'm not seeing a bulb. That could be a hair that's just breaking. I will also give you a caveat here. Hair breakage that's occurring just at the central crown of the scalp is an early sign of CCCA. So acquired trichorexis nodosa, you should be seeing that breakage in multiple parts of your scalp. If you're just seeing it at the crown of the scalp, be mindful of potentially early CCCA. So traction alopecia and acquired trichorexis nodosa, this is actually where I'm mostly having my conversations about styling practices, and that's going to be so crucial. Effective communication is essential. And to get us all on the same page, let's just talk about some basics of hair and how it differs. So all hair fibers or hair shafts have the same structure. There's actually very little difference. There's medulla, you can see here, central cortex, and then this cuticle, which is so important, several layers of cuticle. And hair across all races has the same basic morphologies, and in fact, the same basic chemical composition with 90% proteins, lipids, and sugars. Where hair differs is mainly variability in the shape, the geometry, the color, the mechanical properties, and luster. For the longest time, we have just broken hair down into mainly 3 categories based on race: Asian, African, and Caucasian. Of course, that's not a perfect system, and I think there's more to be desired, leaves that with something to be desired. But for the majority of what I'll be talking about in the next 2 slides, this is from African hair. So when we think about hair shape, the shape of the hair shaft itself, it's actually defined at the level of the follicle, not at where hair exits the scalp surface, okay? So what you can see here, and this is a curly textured hair, is there's kind of variability here. You can see it start to twist even here. And that's because there's asymmetry and cell proliferation and differentiation that's happening at the bulb. So proteins are actually expressed in an asymmetric pattern, which results in the twists and curvature of the hair. Therefore, because of those twists and curvature, there's increased susceptibility to mechanical strain. So as opposed to Asian hair, which actually has the largest diameter and is very straight without curvature, in curly hair, there's variability in the diameter of hair because of the twists. And just at baseline, curly hair or African hair tends to be thinner in diameter. And because thinking about those twists, that makes non-uniform cross-sectional configurations, which translates to breakage and weak points when the hair exits the scalp and when you think about the hair down the length. There's also a less dense cuticle. So those many layers that I showed you in the previous slide that protect the hair, that's less dense in African hair. And the sebum is less likely to fully travel down the hair shaft, which I talked about before. There are also some studies that suggest there's differences in sebum content, though that really hasn't been fully proven. And of course, there are differences in graying, with Caucasians tending to gray earlier, as an example. I thought this was a beautiful, beautiful EM photo. So this came from the Journal of Structural Biology in 2019. And they found that African hair shafts tend to be more elliptical in nature. So it's in contrast to Asian and Caucasian, which tend to be rounder in shape, the hair shaft tends to be more elliptical in African hair. And this high elliptical shape also coincides with a decreased number of cuticle layers. So when you look at hair cuticle here, see these many layers in Asian hair, similarly European, but then in African, fewer. So 1, 2, 3 here. And in fact, what you're seeing is there's a disruption in the cuticle here. So you think about all those inflection points, elliptical shape, the cuticle is impacted. In lack of sebum, the cuticle is impacted there. Well, we know all this about differences in hair, but how do we communicate that with our patients? And the answer is we really don't have a great way, right? So we're good at kind of describing our findings, decreased density of hair, loss of follicular ostia, global thinning, all these buzzwords we use. But from a patient perspective, they want to be able to have categories for how curly is my hair? What's the porosity of my hair? Things like that, which we often do not engage in. But the truth of the matter is we have to be ready to have those conversations because these tools are used and widely accepted in curly-haired populations. So Andre Walker was actually Oprah Winfrey's hairstylist, and he developed a hair typing system where he is essentially describing the curliness of hair. And he breaks it down into 4 patterns. Type 1, I should say 12 there are sub patterns to this. So type 1A, straight, B and C, type 2, which is wavy, type 3, curly, and type 4, you can see here. So you'll often hear a patient refer to, well, I have 3C hair, or I have 4B hair. What should I use? What should I do? Just wanted to give you context that this tool exists for the lay public, so we should be familiar and able to make recommendations. Now, it's a little bit hard with that schematic to say, how does that translate to science, right? We don't have maybe a scientific way to classify hair, and that's true. However, there was a study done in 2007 from L'Oreal, and I think that's telling. This is an industry, hair care. There's so much money behind it, right? So this is a study from 2007, and what they tried to do was kind of expand our understanding and classifications of hair outside of just Asian, African, and Caucasian. So they looked at over 1,400 participants from 5 different continents to look at variability in hair curl, and they used 3 different metrics. They used curve diameter. So they took a piece of hair, took 6 centimeters of it, they washed it, they cleaned it, prepared it, and they did a number of different tests or assessment, one of which, was what's called curve diameter. So essentially, when placing the hair on a glass slide, they used kind of this visual metric to see how much curve was in the hair. They also used a curl index, which is the ratio of hair length when it's stretched versus not stretched, so relaxed. They also used the highest number of waves when the hair was pulled to, I think, like a fifth of its, or 4/5 of its natural length, and then the number of twists that they could see on a relaxed hair. So they used those metrics. And what they found is there's significant variability both across race, right? But even within, and we know that. We know that when we say Caucasian hair, that doesn't mean one thing. There are some Caucasian patients who have very straight hair, and there are some who have wavy or curly hair, right? And that's demonstrated here. So they ultimately developed these 8 curl classifications, and you can see within African, their spanning tends to be more on the curlier end. Asian tends to be straighter, Caucasian as well. Brazilian, Caribbean, and African American kind of in the middle, but definitely variability even within race. So something that needs to be considered. Now, in trying to bridge a gap between this communication tool that exists in the lay public and us in dermatology and how we use and assess this, this was a study I actually did with a group of colleagues. And what we did is we looked at curl pattern as a tool for risk stratification and communication. So this was a schematic we created, again, using what's widely accepted from 1 to 4C. And what we found that actually curl pattern can predict alopecia subtype. So we looked at 74 participants enrolled in this study, and there was significant difference amongst the 4 different curl patterns in terms of the type of subtype of alopecia you had. Most notably between curl pattern 1 and curl pattern 4. AGA occurred similarly across all 4 curl patterns, but the risk of CCCA increased with increasing curl pattern. In fact, in our study at least, which was small, curl pattern does appear to be more significant than ethnicity in determining risk of the associated alopecia subtype. So in addition to dermatologists needing to adopt this as a tool for communication, also it can be used for risk stratification. Let's talk about how we can optimize communication. So this is a document I really love that's coming from Virginia Dermatologic Society. It's actually a packet that was created for patients. I'm happy to share it. I will give them full credit. I took no part in creating it, but it is wonderful. So what do we recommend for our curly haired patients that come in with healthy hair? So this is just a routine maintenance regimen that I would suggest. So you always want to wash every 7 to 14 days with a moisturizing shampoo. Always use a conditioner following shampoo. You should be using leave-in conditioner after washing, and you want to do that immediately after washing because the warmth of the water tends to open up the cuticle and allow for the moisture to penetrate a little bit better. But you'll need to reapply at least every 2 to 3 days. Of course, you want to avoid high tension styling, especially if you're chemically relaxed, and never use heat without a heat protectant style with a heat protectant because that cuticle is already so fragile, right? And we saw that. So just getting into shampoos, you'll probably have some questions about that, but shampoos often have sulfate, which has seemed to become a dirty word, although I would suggest that, in fact, it may not be. Sulfates are detergents, and they're responsible for the lathering properties of shampoos, and they also cleanse the hair. They are anionic, which is actually necessary because they will prime the hair for the conditioner and the moisture that comes within the conditioner. So the downside to sulfates are that if you have too harsh of a sulfate, you really aggressively take off that sebum. And we know that curly hair needs as much sebum or moisturization as possible. So sulfates to look out for that are harsher sulfates are those listed here. So these are some completely sulfate-free shampoos that I do tend to recommend. So Design Essentials, which is really cost-effective. Olaplex, quite expensive, but it's great for straight hair and curly hair. And this is one of my favorite brands, Curlsmith. They have an essential moisture cleanser. But tell your patients you don't necessarily have to be afraid of sulfates. There are gentler sulfates. And in fact, being able to have that anionic presence to allow the moisture to actually penetrate next is sometimes a benefit. So, and that's, you might hear the term buzzword clarifying shampoo. You want to use a clarifying shampoo occasionally. Well, those tend to have usually more of a sulfate presence so that you are cleansing the hair of the oils, at least occasionally. But if you're looking for a gentler sulfate shampoo, consider these sulfates, sodium C1416 olefin sulfonate or sodium lauryl lactylate. These are two of my favorite products with that in them. Now, let's say you see a patient. Another disclaimer, many patients who come into you are going to come in for sebderm, right? So thinking about those general recommendations, they may not apply to everyone. So someone who's coming in for severe sebderm, even though we say you can wash hair every 7 to 14 days, maybe you want to push them towards washing more towards 7 to 10 days, right? Or washing with braids in, which can be done. But if you have a patient who you're noticing has acquired trichorexis nodosa in addition to whatever else they're coming in for, so that you're noticing that breakage, the luster of hair is not the same, that's where I start to tweak that regimen. So instead of just the things I mentioned previously, then I'm going to suggest maybe a pre-treatment, deep conditioning, a protein treatment, and I'm going to reinforce that we need to use a leave-in conditioner. So pre-treatment, what is a pre-treatment? So many on the market, essentially what the thought is that before washing the hair, you would put on some type of oil such that it acts as a barrier from the harsher shampoo that you're about to use. So it allows some moisture to be penetrated before you go ahead and wash. I often just recommend coconut oil for this. Coconut oil is often too thick for some people to leave on indefinitely, but if you use it as a pre-shampoo treatment, it works. There are also many products that you could get that are suggested for a pre-wash regimen. And then deep conditioners. So the thought behind deep conditioners is there is a lack of moisture, right, that is occurring in curly hair. So these provide, usually have fatty alcohols, other ingredients like glycerins in them or silicones that will allow for repair of the cuticle in terms of oil-based types of products that are infused to increase the moisture in hair. So essentially what you're doing is you're washing with a shampoo, you're using a normal conditioner, you're washing out that conditioner, and then you place on a deep conditioner, which you would leave on for 20 to 30 minutes. If you can, allow some gentle steam or light heat to be added to open up the cuticle, that's also of benefit. So these are 3 that I like to use. And the ingredients you're going to be looking for are sterile alcohols, acetyl alcohols, which are fatty alcohols, which often soften the hair. So the fatty component is able to penetrate the hair, but the alcohol pulls in the hydrophilic water moisture. You're looking for citric acid, benzoic acid, glutamic acid, and these leave a positive charge on the hair and reduce frizz. You'll also see dimethicone, which is a silicone. So anything that ends in cone is a silicone variant, which will help provide shine and smoothing. They do sometimes leave a coat on the hair, and these dimethicone and glycerin will happen not only in deep conditioners, but also in some leave-in conditioners. Glycerin, that's a humectant and attracts moisture. Now, what's a protein treatment? And I should say deep conditioners, I tend to recommend every other week to every week following washing of the hair. A protein treatment, however, is a bit different. Usually I'm recommending this monthly. Protein treatments have a true protein in them because we know that the cuticle is made of keratin, and based on the elements, based on heat, etc., we end up developing gaps or holes in that cuticle. So using a treatment that provides protein to kind of fill in those gaps is of benefit. So these are some examples of protein treatments that I like. And again, what we're trying to accomplish is repairing that cuticle. Now, leave-in conditioners and moisturizers are needed in curly hair. These should be used every 2 to 3 days. And an analogy I like from a mentor of mine is when we have a patient with eczema, and they have dry skin, what do we suggest they do? We suggest they do a soak and smear, right? So you open up the skin cells a bit, you put on moisture that allows it to trap in. A leave-in conditioner moisturizer is essentially a soak and smear for the hair, thanks to Dr. Crystal Aggo, who's taught me that. So they're mimicking sebum. So you want the hair cuticle to be slightly open. So perhaps you'd wet it a little bit, or you do this, of course, post-wash, and then you're putting on that moisture in the form of a leave-in conditioner. And these are 3 that I really love. These are probably 2 of my favorites. What do you want to suggest to avoid? So MCI is a product. It's a preservative that commonly causes contact allergies. So if you're developing any redness, itching, of course, look for MCI in your products. Parabens and phthalates, the public has caught on to these. These are preservatives. Parabens are often pretty easy to recognize, and many products now will say paraben-free or phthalate-free. But they're thought to be endocrine disrupting chemicals. And that's kind of the impetus behind some of the conversation that's happening with cosmetic products and cancer now. So if possible, avoid parabens and phthalates. So what is the role for hair oils? So patients will often come in and say, oh, I'm oiling my scalp. And I often advise against that just because oil is produced at the scalp and has trouble making it down the hair shaft. So really what needs moisture is going to be not at the level of the scalp, but at the level of the hair shaft itself. So I tend to believe hair oils really mainly do a couple things. They provide shine, they help to seal the cuticle a bit, and they protect against frizz or the external environment. So you can put an oil on before you go swimming, for example, just to be a first line of defense. But those are the main roles I see for hair oils. And caution, oil is not a catch-all term. So we think of oils as either essential oils or carrier oils. In the realm of hair, mostly people are using carrier oils, but just to clarify, essential oils are oils that come from plants usually that have medicinal or healing properties. So thinking lavender, peppermint, rosemary, which does have some benefit that it's comparable to 2% minoxidil. So sometimes I will recommend that for patients who want something natural. These are often in really concentrated forms, so they need to be diluted in order to prevent an irritant or allergic contact allergy. And that's where carrier oils come into play. So carrier oils are used truly for moisture or to dilute essential oils. And based on their molecular structure, they can either penetrate the cuticle and make it to deeper levels of the hair shaft, or they can just be a sealing oil. And so when you think about which oils are able to penetrate, you have coconut oil, avocado oil, olive oil, shea butter. Sealing oils, going to be castor oil, jojoba oil, argan oil. So if you have a patient who comes in and says, oh yes, I'm using castor oil as my moisturizer, you can tell them, well, actually, that doesn't quite make it to deeper levels of the hair shaft. So probably what it's doing is staying on the outside portion of your hair and not providing significant moisture. Hair, and in summary, hair care is not, and hairstyling, not one size fits all at all. So these are products that I tend to like and recommend. That packet has several other great products to like and recommend. But there are times when I share product recommendations with patients and they don't end up liking them, and that's totally acceptable. I mean, everyone's hair is different, so sometimes you have to play around. But this is a question I get commonly. How should I style my hair? And again, this is also not one size fits all, but I just want to introduce you guys to some buzzwords that you might hear. So what is natural styling? Natural styling is thought to be any hairstyle that doesn't require chemical modification. So thinking of wearing hair in a fro or wearing hair twisted or in plaits, etc. Now, some may also go so far as to say natural doesn't include heat. I think you can introduce heat and still be considered natural, but that's kind of just semantics in terms of naming. But natural really means no chemical modification of the hair. What's protective styling? So protective styling is something like braids or a sewn-in weave. And what is meant by the term protective is reducing the hair shaft itself from heat or elements. So when you braid hair in 3 parts, less surface area of the hair is exposed to the environment or to heat, for example. And so therefore you are protecting the hair. So that's why it's called protected. However, I will put an asterisk here. Oftentimes protective styles put more tension on the hair. So things like braids, they may protect your hair shaft to a certain degree, but they will put a lot of tension and pressure on the hair at its root, which can be damaging and can cause, of course, traction alopecia. There's Brazilian blowout, which uses a keratin solution and heat. Often comes to mind because it has high rates of formaldehyde. There's using heat to break disulfide bonds to result in straightening, as well as chemical relaxers, which uses a chemical to break those disulfide bonds and relax or straighten the hair. But many of these products contain endocrine disrupting or cancer causing chemicals. And with our increased rates of cancer over the years, people have turned more and more to looking at what's in some of our beauty products to find potential causes. So previous studies have suggested that hair product use via endocrine and disrupting chemicals may be linked to breast and ovarian cancer. Bad actors may be formaldehyde releasing chemicals, PPD, etc. And this is a recent study that's hot off the press, December 2022. You may have seen it in the news over the past year. So this looked at the SISTER study, which is a prospective cohort study of women of all races who have one family member with breast cancer. Over 50,000 women enrolled from 2003 to 2009. They collected many different demographic points, but they also looked at some beauty trends like hair straightening and dyes and the frequency of use of those. And what they found is that the use of hair dye was not associated with an increased rate of uterine cancer. However, there was a high hazard ratio of uterine cancer among women with straightener use in the past 12 months, with a hazard ratio of 1.8. This study, I should say, had 85% of participants were white, 7.4% were Black, and 4.4% were Latina. There has been criticism of these findings, suggesting they're not generalizable. So really this study didn't look at or define what hair straightening was. So was that heat? Was that Brazilian blowout? Was that chemical relaxer? So it didn't specify the modality used. So it's hard to make assumptions from that. There, the white participants comprised 86.2% of the uterine cancer group, just reemphasizing that the numbers are very low. So there was a low percentage of Black and Hispanic patients included, in the beginning, and that's true and reflected of those that developed uterine cancer. And then we know uterine cancer can be associated with insulin resistance, economic status, family history of cancer, cardiovascular disease, and it doesn't look like those details were teased out to see how they are covariates. There's also precedent for this in terms of hairstyling and breast cancer, and what they found is that in the same study, in terms of the sister study, the prospective study, in Black women, permanent hair dye use carried a 45% increase in breast cancer risk, with a higher frequency of use positively associated with more common use of hair dye. And then point that I found interesting is 74% of Black women in that study endorsed using straightener use. Straightener use carried an 18% higher risk of breast cancer risk in that study. And so I guess, what are the conclusions? I'm not sure that we're totally able to make them. I think it's safe to say that we have to be cautious about these hair care products and more diligent in identifying some of the chemicals used in them, and more accurately tracing their correlation with future cancers if they are endocrine disrupting products. And also, why are we seeing perhaps a discrepancy in Black women developing these things? And there are studies to show that hair products marketed to Black women actually have increased rates of endocrine disrupting compounds. So when we talk about equity, as was mentioned so gracefully in the prior talk, think about all the pressure there is around Black women and hairstyling in a particular fashion. And if you have to make those modifications and changes to fit in society, yet you're faced with a set of products that may have increased rates of endocrine disrupting compounds. So that is not health equity, right? So we have to think about that a little bit better. Here are some patient-oriented resources that you can share. Dr. Agu has since released a number of other books. They're all excellent, including some for kids hair care. So just to summarize, early accurate diagnosis is crucial for all patients, including those with curly hair. Hairstyling practices have been linked to traction alopecia and acquired trichorexia nodosa definitively. Less reliably in CCCA, especially for hot combs and chemical relaxers, it does seem as if there may be some component of high tension putting you at risk for CCCA as well. Thoughtful, culturally sensitive recommendations are required. Keep in mind that you can use curl pattern as a way to communicate and connect with your patients, and perhaps even as a way for you to risk stratify your patients. And hair care is not one size fits all. We have to be culturally sensitive in understanding the implications that, asking an individual to change their hairstyle may have financially, societally, in the workplace, etc. So, really do this as shared decision-making conversations, presenting the data we, are aware of. So I want to thank you for inviting me to speak. It's really an honor. It's a topic that I could talk about all day, but we won't do that because you have so many amazing things to learn. Again, thank you to Dr. Allen for inviting me, for everyone for joining, and for the amazing lineup of speakers that we have to hear from today. Thank you.
Thank you so much, Dr. Krueger. So informative, a lot of great practical information for all of us. We will see if there are any questions at this time. If you want to stop sharing, and we'll see Dr. Kanadia.
Yeah, thank you, Dr. Krueger, for that talk. The first question was, are you doing labs for all of your hair loss patients?
Excellent question. So for the most part, I do not do hair loss labs on most of my patients. I tend to do this if they have extreme shedding that I can't explain. Then I think about things like TSH. So I'll order it then. I also do it if there's acquired trichorexidinosa or breakage. And the labs that I tend to order are TSH, ferritin, which I replete to 50 or 60, vitamin D, which I replete to normal, and zinc, which mainly comes into play for those with nutritional issues or diarrhea. So hair breakage is a big one, and then hair shedding, which is persisting beyond my TE window. Also, I would sometimes throw in a prolactin if someone who has androgenetic alopecia or patterned alopecia, but they just seem too young or something else about the story doesn't fit.
Yes, Dr. Krueger, this is Clarence Wild in Oklahoma City.
Hello.
How you doing? I really enjoyed your presentation.
Thank
One
you.
question I had, though, was in terms of, you mentioned shampooing every 10 to 14 days. I started practice in 81 when the Jerry curl was a popular hairstyle. So I've gone through a whole series of hairstyles over these many years. And one thing I've seen was actually the problem with trying to encourage patients to shampoo because of the cultural, I'd say, conception of and women and Black women, shampooing every 2 weeks. When they had seborrheic dermatitis or some disorder, I said, okay, you need to shampoo more often, and even up to 2 times a week. Now, you can imagine the discussion I had with a lady of color back in 81, trying to encourage her to shampoo more than every 2 weeks. In treating seborrheic dermatitis, I can't find a case where I can encourage someone, or even in a healthy hairstyle, to shampoo every 7 to 14 days. My conception was that if you cleanse the human body, pretty much every day or every other day, then you should cleanse your scalp at least once a week. That'd be the minimum for just a healthy hairstyle. So I would just say I have a little difficulty with your recommendation of every 7 to 14 days and maintaining healthy scalp care.
Yes, thank you. I think so. This is something that has to be a shared decision-making conversation with your patient. This is where it really helps to get to know what your patient is doing and how they're styling their hair. So as you so astutely point out, when someone's going into the shop every 2 to 3 weeks to get their hair styled and paying hundreds of dollars or such to get it done, they're not going to take very kindly to being told to wash their hair more frequently at once a week. And it's hard, right? If you're getting styled at the salon, it's hard to do it every 7 to 14 days. Here's what I would suggest is I kind of present the pros and cons of it, right? So because in curly textured hair, the sebum's not making it all the way down, I tell them there is that buildup that happens there. I can sometimes adjudicate that with some topical steroids, but some of it actually needs to be mechanically removed. So working with patients to decide, okay, well, if you have braids, are you able to wash with your braids in? And oftentimes they'll tell me, yeah, oh yes, it makes them a little bit more frizzy more quickly, but yes, I'm willing to do it. Also, if a person has seborrheic dermatitis mainly along the frontal hairline, you can sometimes, get away with rubbing the shampoo in here and then wiping it off with a rag after it sits for 10 minutes. So there are some tricks you can use. I do find that oftentimes if you just have that conversation with the patient, we have to mechanically remove some of this scale and, sebum in order for the yeast to not have such an environment to thrive. We are able to come together on a strategy that would work for them.
Well, and Dr. I can really respect and appreciate that. But I've had that conversation again over 46 years, so I've had pretty much every conversation you can imagine. But still, what I'm saying is that most times in my generation, it wasn't a light oil, it was a pomade. It was a grease that now was applied to the hair, was applied to the scalp. And these were still exist, in many businesses that sell products to people of color. These are thick pomades. And trying to change the concept of thick pomading of the scalp and of the hair and the scalp, again, it's something that I think we should address in terms of trying to promote less oil and less pomades and more shampooing. But again, that's just my perspective on that discussion.
No, you are 100% correct. And thinking back to the point about oiling the scalp, I don't recommend that people oil the scalp. It's counterintuitive based on what we've been taught over many years,
Oh,
but all
absolutely.
you're doing is giving the yeast more oil to feed off of. So yeah, it's a hard one, and I totally believe you that you've had that conversation many, 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 many times. So
But
appreciate
thank you
your
for your
wisdom
presentation.
there.
Thanks for
Thank
your
you.
presentation. I enjoyed it.
Thank you.
Thank you so much. I know we're a little past, but I tell you, there's so much. And so we'll have you, if you're able to, just look through the chat and maybe answer individual questions further. And she maybe can leave her information on contact if you have further questions that way. But I tell you, thank you so much. Such clear information. I even have some questions of my own, but I will ask you later. So thank you so much.